I'd like to begin by acknowledging the traditional owners of the land on which I'm speaking, the Turrbal people, and pay my respect to elders past, present, and emerging. Hello everyone, my name is Danielle Currie, and I'm the Senior Simulation Modeler at the Sachs Institute, and I'm here to present our work for accelerating risk factor reduction in a systems model of chronic disease burden for myself and my colleague Jackie Davison. So I know I'm kind of preaching to the choir here, but as we all know, there's an enormous burden of chronic disease in Australia. And the Australian Burden of Disease study tells us that not only is disease a large burden on our society, but a big part of it's preventable through the reduction in modifiable risk factors. We also know that risk factors of chronic disease are numerous, interconnected, and play a role in many different diseases, so they don't sit in isolation. We know that the prevalence of these risk factors is changing, and the burden associated with them therefore changes too. So it really makes the situation quite complex as it changes over time. And so, given all this complexity, it's no wonder that when put in a position to make population-level decisions about disease prevention, many decision makers look a little bit like this. And so, when we think about it, given that we know more and more about the linkages between risk factors and disease, and we can also look back and see the way that the prevalence of each risk factor has changes, our group decided to look at, can we use this information to look into the future to see what impact public health decisions might have? So as modelers in our group, we kind of thought about the question in this way. We thought, can we capture the complexities of the modifiable risk factors and their related disease burden and costs using system dynamics modeling? And if so, what could the simulation model tell us? And so we built the GoHealth model. So what is the GoHealth model? Well, this conceptual diagram we have on the screen represents the model constructed in Stell Architect. It's a system dynamics model that uses the Australian population, the top 9 modifiable risk factors according to the Australian Burden of Disease, and the top 16 chronic diseases, again according to the Australian Burden of Disease, that are related to those risk factors. So we've included ones such as ischemic heart disease, a variety of cancers, and COPD, but we have excluded diseases like lower back pain, dementia, and drug use disorder. It also measures burden across both the economic and health burden, and it measures, it includes measures of changes within the demographic population to really capture the way that Australia's population has changed over time. So the simulation starts in 2017 and calculates forward. So this research project began by taking an overview of the known evidence around risk factors and their related burden, both health and economic, and explored all of these related variables, starting with the Australian population in a simulation model of Australia's preventable chronic disease burden. And there were 2 main key objectives that are written on the screen. And we'll talk through how we interpreted these objectives and what we ended up producing, and then revisit this to focus on 4 key insights that we got out of the model. So really the objectives were to develop this system dynamics model that included the range of risk factors and the chronic diseases to inform how policymakers could invest in targeted and coordinated way across a portfolio of risk factors. And we wanted to use this model to help the public health community make more united and a compelling case for investigating chronic disease prevention. So the original objective of the GoHealth model was actually a multi-stage project with significant preliminary statistical data exploration and applying the system dynamics methodology to the calculation and projection of chronic disease burden. In the second stage now, we had a new focus on really an operationalized, comprehensive model of the preventable chronic disease burden. So this is the process of data exploration and gathering prior to the model building. At several points, we've engaged with representatives from the Australian Chronic Disease Prevention Alliance, including for heart failure, diabetes, kidney, and coronary care, only at high levels to assess the appropriateness and potential interest of this model. We also engaged from a data perspective with the AIHW's Burden of Disease team and separately with ACT Health. From a data preparation perspective, we got our data from 2 main sources, from the AIHW's Australian Burden of Disease study, and in the absence of data, we then went to the Global Burden of Disease study, which is published in the Lancet. We also made really good use of the WHO EPI tool DISMOD. It's good old DISMOD. And so really, how does the model work? So within the model, we have the risk factors and the disease connected to each other. So let's take one risk factor. And look, we asked the question, how intense is the prevalence of a risk factor in the population? And we created a distribution of the prevalence of that risk factor with the number of, or percent of the population on the vertical axis, and the intensity of that risk factor on the horizontal axis. And there is a hypothetical line that states where people who have below that level of risk have no risk of getting that particular disease. Individuals above it have a staggered or kind of tailored amount of possible risk. And we have our diseases where we model out how the risk factors relate to the disease by asking what level of risk of a specific disease does this level of prevalence equate to. We take, again, the intensity of the risk factor and the amount of risk it poses. We combine those two together to ask questions like how much of the ischemic heart disease that is prevalent in the population can be attributed to, for example, high cholesterol. So we attribute that portion using these calculations, but then we have to control for the effect that other risk factors have on cholesterol. For example, diet and exercise control cholesterol, which then again contributes to the burden to ischemic heart disease. But then we also have to control for the effect that cholesterol has on other risk factors. So a portion of cholesterol's burden actually sits within the blood pressure burden. So you can see there is this overlap. And that helps us understand what is the attributable portion of the disease that we can attribute to cholesterol. So we do that across a number of diseases, a number of risk factors, to combine the contribution of all relevant risk factors to that incidence of disease. We put that into the number of, to controlling the prevalence of that disease at any given time, as well as separating out the amount of the disease that is not attributable to the right risk factors, which is then used to calculate the prevalent cases. We also take into account things like remission, the number of people who die from the disease or die with the disease, as well as aging within the population. We combine this together to get the disability that's attributable to that disease. And then across the whole suite of diseases, or the sequela within that disease, we're able to get the amount of risk that's attributable to that one disease. And then we do that for all of the diseases within the model. And so we could go into the really kind of outputs of the model, but I think what's actually more interesting is 4 model insights that we got through the process of making this. So the first insight that we got, the learning that we got from this process, was that risk factors overlap a lot. So if we remember when we were looking at how much of ischemic heart disease that is present in the population can be attributed to cholesterol, for example, a portion of it, but then a portion of that is connected through other risk factors, but then a portion of high cholesterol is done through blood pressure. So what can we really learn about this is that they're not additive. If we remove the burden from blood pressure, it doesn't remove, without considering how much of the burden is within high cholesterol, we will likely be overestimating the effect of that particular intervention. So this really stresses the need to look at risk factors in combination and in the context of other risk factors. Otherwise, we collectively are not accurately measuring the effect of interventions. Making this. The second kind of interesting input we got is that it's really important to comprehensively measure impact. So the chart below here shows 2.2 million DALYs that are related to those included risk factors projected in our model, and divided into the key diseases. We have the risk factors here and then the key diseases over here. And so the importance of looking at risk factors in combination is that if we were to do an intervention on, say, smoking and only look at it in the context of ischemic heart disease, we would only be capturing a very small portion of the benefit that society and health achieve. But if we were to look at smoking in relation to all of the different risk factors that is connected to, we can see that it has diseases it's connected to. An intervention for smoking would bring about health impact both from the perspective of ischemic heart disease, lung cancer, COPD, a number of diseases. So it's really important to comprehensively measure impact across the whole suite of diseases. It's also important to note that the unrelated diseases is actually bigger than all of the connected ones. So again, it's important to always think of everything within that context of making this. Another interesting thing that we learned was that things aren't moving in the same direction, both within the risk factors and amongst them. So within this particular risk factor, if we look at, for example, hypertension, within hypertension, some age groups are the prevalence of hypertension is going up. Other age groups, the prevalence of hypertension is going down. So we can't really group it together as a population and say overall hypertension is moving in one particular direction, because it's moving in a lot of different directions by different cohorts. So when you're targeting initiatives, we really need to make sure that we spend the time to see how it's affecting the different age groups. Making this. And lastly, The late great Maya Angelou once said, "You can't really know where you're going until you know where you've been." And she probably wasn't talking about risk factors and disease, but there's some learnings that we got from this. So understanding the trends driving risk factors in the population is key to successfully modeling the issue. And for this model, we required 9 trends because diet was separated into 2 components. Additionally, we needed the data to be in a consistent format, preferably from measured, not observed sources. So if we look at this chart that we have here, we have across the different risk factors, some risk factors had 2 data points, some had 3, some had only had it across both age and gender, others had it only across age but not gender. And as we all know, 2 data points a trend does not make. So it really became evident that we didn't have a consistent way of measuring risk across the population in a way that could allow decision makers to make accurate decisions. And so if we think of the original thinking behind the project, we came to realize that the current body of consistent age and gender specific data on risk factors is really lacking, especially when compared to the disease data. But regardless to this, we still have to make decisions. We still need to look forward and see what is present and growing. So we collectively, as a public health community, need to collectively act to remove that fog so that we're in a position to learn from the past to make better decisions for the future. So the National Preventative Health Strategy is one step in a good direction for that. So the actions proposed in the new National Preventative Health Strategy will hopefully support this, especially the National Data Framework, which will hopefully incorporate nationally consistent measures and definitions to support regular collection of relevant risk factor data. One priority in the strategy is to develop the national prevention indicators with definitions and measures and national prevention monitoring. So in conclusion, what have we learned? Well, we've learned that risk factors don't work in isolation, just like people don't. Infectious disease modeling during COVID-19 pandemic has at least taught us that. Chronic disease modeling can capture all of the variables, or at least the most important ones, using systems modeling. We also learned that we can learn about complexity and interactions in mediation using this existing tool that we built, just as we've shown. But we've also learned that to make this a useful policy tool for policymakers and for all those wanting to look into the future of disease burden and learn more about how we can achieve the aims of the new National Preventative Health Strategy, we need better quality and more frequent data. Right now, we're kind of, without having that good database to go on, the model is kind of running blind. And so once we have more quality data, the model will become a more and more useful tool. So we want to say thank you to the AHW in particular for the support with data access during this project. We'd also like to thank the Prevention Center and their funding partners for making this research possible.